He is the deputy, he is the associate dean and he is associate dean of Yenapoya Medical College and deputy director of Yenapoya Center for Faculty Development, Yenapoya Deemed to be University, and he is a professor of community medicine in Yenapoya Medical College. He has passed his MD Community Medicine, postgraduate diploma in hospital administration, postgraduate diploma in bioethics and medical ethics, and he has published more than 56 papers in national and international journals. He is a FIMER fellow and introduced PRA methods in community diagnosis, developed comprehensive digital HDSS. He has introduced best practices in teaching, learning, assessment, services, and research, extramural grants, ICMR, Tata Trust, Karnataka State OR, and Tech for Development, from where he has received the award grants. And the awards to his honor are awarded for excellent contribution in National Polio Surveillance Project, surveillance medical officer. He was a mentor for structured operational research training initiatives organized by the union. A lot of things to talk about Abhay, but we would be very keen to listen to Abhay. The stage is yours, Dr. Abhay. He is talking, all of you know, about the basics of public health ethics. Over to you, Dr. Abhay.
Yeah. Thank you so much, Dr. Kulkarni sir, and thanks for reviving the IAPP again. Sir is the pioneer for the IAPP initiative as a scientific sessions for the postgraduates of Dakshin Kannada district and Udupi. Now, happy and good evening all, dear students. So I'll be sharing my slides now.
Before you start, Abhay, one more announcement, sorry. All participants, please note that at the end of the session, we will be sharing the feedback form in the chat box. All of you have to fill the feedback form, and only then you will get the auto-generated certificates for attending this session. Okay, thank you. Yeah, continue, Dr. Abhay.
Yeah. So good evening once again. Today, next 40 minutes, we are going to discuss about the basics of public health ethics. You can ask the question in between, or we can have the question answer in the end. It is, you can put the questions in the chat box as well, or you want to put some comments or you want to add, you can put it in the chat box, or in the end we will discuss. So the specific learning objective of this session is we should be able to understand the importance of public health ethics, paraphrase the idea of community engagement, enlist the principles of public health research ethics, to identify the ethical issues in public health service and research, and to discuss how community engagement enable researchers to address the ethical issues. Now, the first thing, why public health ethics? We have the ethics for the individual, biomedical research ethics for addressing the individual, and the ethical guidelines are originally designed to protect the individual human research subjects. Ethics in public health, more importantly, it is apply for both practice, that is surveillance, service, notification, and etc., and research, both. And the benefits and risks are not limited to an individual, but influence communities, population, and environment. Potential to exploit the vulnerabilities of the communities. Public health ethics is concerned with ethical issues related to public health policy, allocation of health resources, preventive measures that can impose limits on individual freedom and autonomy. We have seen in the current pandemic how the individual freedom can be limited, and because of the Epidemic Act. And so public health raises complex relationship between the state, its policies, and society involving individuals and organizations. Now, it is difficult. There are difficulties in clear delineation of boundaries between practice and research. And the problem is the people who have limited access to healthcare may misunderstand the research as an opportunity to receive medical care and other benefits besides financial incentives. So they may not, they will be, if you could not be able to explain or help them to make a rational decision, they may consider research as a utility. Now required. What is required is a process of ethical reflection. We must reflect. We should have appropriate protections in place. There should be ethical oversight. Community engagement strategies should be there to minimize the ethical issues, and the governance mechanism of implementation of the programs and policies should be in place. Now, as we know, community engagement is, we are usually involved in community participation. Rather than community-based participatory research, most of the research are community-placed research. So we are involved in passive participation of community, that is informing the community. Then we sometimes consult the community, take the feedback. But when we involve the community in making decision about what they want and what are the problems, to understand their needs and to find out the solutions, what solutions they want through PRA approaches, workshops, then the participation of passive participation, it will move to the active involvement of the community members. Then if the community is a part of action research or collaborative participatory research, then they can relate the success and failure of the program to them. And ultimately, our focus should be in community engagement should be to empower the community about the decisions in the, so that they should be able to make decisions and they could be able to get the benefit even after the project is over. Community engagement per se is working collaboratively with and through the group of people who are affiliated by geographic proximity, special interest and similar situation with respect to issues affecting their well-being. Now, if you see the community-based participatory research, if there is a less community involvement, we have seen in the previous slide, informing community, consulting community, involving community in decision-making, collaborating and empowering. So the spectrum of involvement of community, if it is only informing and consulting, then it is less community involvement and it is a researcher-driven investigator. But moment we are, there is a complete community involvement and there is a community engagement and there are communities a part of a collaborator in the research, then it is a community-driven research. So if you are in this spectrum of the study, community-based study or public health intervention, then there are ethical issues are more. But if you are in this spectrum where there is a complete community engagement and engagement strategies are there and there is a complete community involvement, then we could able to address the ethical issues. We are going to see that in future slides. Now, there is a difficult to differentiate between the public health practice and research, and it is a big challenge for the public health ethics. For example, the public health practice research related are the surveillance activities, collection of vital statistics, disease reporting and registries, outbreak investigation, contact tracing, use of preventive intervention and health promotion activities, monitoring of the program evaluation. For example, we do mass drug administration evaluation of the program, immunization coverage evaluation program. There are existing surveillance programs, enforcing mandatory requirement like screening, treatment, immunization, notifying the disease, sometimes quarantine. So these are public health practices. Now, surveillance, 1 minute, I need to minimize, change the view option. 1 minute. Because I want to mask the first line. I can minimize it. Just a minute. No issues. So the surveillance activities which are there, they may be placed under the exempt from the review. Whenever there is a surveillance program like tuberculosis, NICSHE data we are taking, they may be exempted from review category in specific situation where the sole purpose of the exercise is refinement and improvement of the program. So the program evaluation and the surveillance, why we do surveillance, we collect the data, continuous scrutiny of ongoing event for taking corrective measures. So we are doing as a part of corrective measures to improvement and refinement in the program, then it will be exempted from the review category and proper ethical review must be carried out for program evaluation. But you have been asked to evaluate a program, it should go through ethical review and consent waiver or can be obtained. So it should follow the process of review and then and the permission from the concerned public health authorities. Now, if you are involving demographic data and registries, prior approval of the competent state national authorities from the community leadership is required to set up a demographic surveillance. If you are in a government hierarchy and there is a demographic surveillance site, then the permission and all, you have to take the permission from the state and national. Or you are establishing a demographic surveillance site or a health and HDSS or health and demographic surveillance site, you must take permission from the competent authorities. As long as if you are not going to use this data for research purpose, there is no need for ethics review and ethical approval. But however, if the research studies to be undertaken, if you are going to use the data of the demographic surveillance site for the research and publication, then ethics committee approval is required. For registries are established as a part of research project, or if the data emerging from these registries is proposed to be used for research, prior approval of EC is required. So we establish a HDSS site and we are going to use this data for research. Then we have taken ethics approval, not only from the institutional ethics committee, but also from the state ethics committee, because we are collecting the data from our over and above our rural and urban field practice area. Continuing to that, on the other hand, the registries that are set up as a part of public health program by national authority may be exempted from the ethics review process if the data is de-identified, but the subject to governance process and certificate, we can though there is an exemption, but if the data should be anonymized, de-identified, and the proper governance process means we should follow the set protocols and SOPs what we are going to take for doing the demographic data analysis or program evaluation. There should be proper SOPs should be followed so that one should able to take care of the risk. There are 3 types of risk, even if you are using the data, which is a surveillance data, which is a risk to privacy, risks to self-determination, risk to liberty, and risk to justice. So these are different types of risks are involved, even if you are collecting the secondary data or the demographic data. So that's why proper governance process of the data management should be followed. Now, even we are using the secondary data or the surveillance data for the research purpose. WHO has given for the postgraduate, in the reference I have mentioned, WHO has given a guidelines on ethical issues in public health surveillance, and WHO has given 17 guidelines how to use surveillance data to minimize the ethical issues. However, in spite of that, if you don't manage the surveillance data confidentiality, proper protocols are not followed, then the type of harm we may able to the participants may face are these: physical harm, legal harm, social harm, economic and psychological harm. If suppose if the data is related to, if you remember the early first lockdown, when there was a lot of even stigma and discrimination was associated with COVID-19, that time you can imagine if they never used to allow people to enter the village if they are coming from city as a part of lockdown exercise. So public attacks we have seen, house partner abuse, domestic violence, delayed or inadequate treatment. So physical harm also, if you release the secondary data, those who are affected. Legal, you can have arrest, prosecution, death penalty, expulsion. Social, discrimination, community discrimination, isolation. Economic, even the loss of employment and revenue. Psychological and emotional distress and trauma. Even if somebody is a diabetic or hypertensive, we are, because of revealing the information, we are making them to revisit the trauma of cancer, trauma of diabetes, trauma of hypertension. So we are making them revisit the revisit the trauma of making them realize what they are going through, their disease or the condition. So these are the type of harms one can face if you don't manage the surveillance data proper. Now, there are certain principles, just like there are 4 cardinal principles for biomedical research, like autonomy, beneficence, non-maleficence, and the justice. So similarly, ICMR has given in the chapter 8 of ICMR guidelines of 2017 about principles for public health research ethics. The first principle is principle for respect for autonomy, rights, and dignity. And just like the individual rights and dignity, there are rights and dignity of the community. Because when you are dealing with the data, when we disclose the data also, there are a lot of issues. If you are stigmatizing the communities that the individuals or more number of people with sickle cell disease, the rights and dignity of the community or the group is also at danger. So one more important thing with respect to the public health ethics or research is autonomy is relational. In case of individual research, there is a autonomy is individualistic. Means either we have to take permission from that individual can able to take a call, but here the decisions of one individual is going to affect the family. The family's decisions are going to affect the society and community because there is a lot of interdependence. Say suppose somebody want to take part in the contact tracing. Somebody don't want to take part in the immunization against COVID. So their decisions are going to affect the other community members. So autonomy in public health research ethics is relational. With respect to autonomy, consent is an important component. So there's a two-level consent process. First level is the gatekeeper. Now, who is the gatekeeper in the case of community public health research? Say suppose you are entering an institute, somebody is going to open gate for you. The security person will open gate for you. And one who opens the gate of community and help the researcher or the service provider to reach out to the beneficiary, these are the gatekeepers. If you want to deal with the under 5 children, then who are the gatekeepers for the under 5 children? It could be the Anganwadi, it could be the school teachers. So one who can open the gate and help you to reach out to the beneficiaries are called as gatekeepers. So depending upon the project, service, or the research, the gatekeepers will change. The key informants or those who are community stakeholders are going to change. So they are the one who are going to be the first consent. Second is the individual consent. So written voluntary informed consent is the norm in research. Even if you take the consent of the community or the gatekeepers, then also the individual consent is critical and important. Now, when we can, when there is it is not possible to request an informed consent from every individual to be studied, agreement or a representative of a community or group should be sought, but the representative should be chosen. If you want to give the onus of decision making with the community representative members, then one must ask a question that who represents community. So what are the traditions in that village, how or the area, how the decisions are usually made in that village, what is the political philosophy and the community groups. That question we must ask that who represents community. In no case may permission from the community representative or council replace the requirement of competent individual voluntary consent. The researchers should strive to ensure that the individual agree to participate in the research without any force or undue inducement from the community leaders and representatives. Sometimes it happens that as a part of taking pride or taking some leadership, they will say that I will take care, don't worry, we'll take care of the consent. We don't want, as a researcher ethics point of view, we don't want that way of attitude. We need to understand in which capacity they are going to able to explain the research component and how we could able to improve the understanding of the individual through the gatekeepers so that they can take their rational decision. Now, we are also given the waiver of for routine data already in the service been collected routinely in the and where obtaining consent is impartial, that is stored anonymous data, biological samples, surveillance or administrative data, personal not identifiable data. Only under such circumstances consent waiver can be given. That also when the primary purpose is refinement of the improvement of the public health program and the health related registries. In that scenario only, keeping in mind the guidelines of we have seen what type of harm disclosure of surveillance data can cause. Keeping in mind all these guidelines, we can able to take consent waiver, but we have to go through the process of ethical review. Now you are going to do a research for one purpose. you are going to collect the data for, say, suppose one sample you are collecting for blood sugar, and then again you want to conduct one more test on that, then reconsenting is required. Whenever there is a change in protocol, new information you are going to collect, even with the stored data, then also we need to have a reconsent rather than collecting the data on your own. Second, we have seen so far about the first principle of autonomy and the relational rights and the dignity of the individual, where the autonomy is relational two-stage process of consent. Now, the second principle is principle of beneficence. Just like in individual, we go for maximum good for the individual. Here, the beneficence is for the public good through societal benefits. So always when in the protocol we'll write what are the societal benefit, what way the society is going to benefit from the project. So we need to look for the larger societal benefit. Third principle is principle of non-maleficence. Now the harm we are going, potential harm is not only collecting the data, but disclosing the data, there is a potential harm, even if it is a data related to service. So public health service, which is program, surveillance and all, and research. Whatever may be the data, subsequent disclosure, we have seen the type of harm we can cause even if it is a surveillance data. So then there are certain principles to reduce the harm. Now the first subtype of the principle is the harm principle. If you want to disclose the information, say suppose we want to disclose the information about somebody's COVID positive for contact tracing, then there has to be strong ethical justification to do that. Okay, so if you are giving permission for notification, contact tracing, active surveillance, such strong ethical justification should be there for practicing the harm principle. Now, even if you are harming, then the principle of least infringement. Now, even if there are movement restricting the restrictive means you are using, then it has to be least restrictive. So previously we used to quarantine them, then the quarantine facility was hospital, then the quarantine facility, then we said that there should be quality of life. The COVID care center should have facilities for recreational, they should have proper balanced diet food, there should be availability of for any mental health or any consultation. So even if there is a restriction, the restriction should be least restrictive means. Principle of proportionality. If you are, there are some burdens, then proportionately there should be some benefit as well. Principle of social justice, similar to the individual, but here the context is the benefit and burden of the public health research should be equitably distributed across all study groups. Always we must remember that research that retains or enhances existing inequalities should be avoided. At least even if we could not able to improve the inequalities, but it should not adversely affect the existing inequalities. Fifth principle is principle of reciprocity. So disproportionate share of risk gets some benefit. Here I would like to give example that when the as a healthcare providers, we were in the front line for the in the COVID pandemic. And there are some more frontline workers, which are law enforcement agencies, sanitation workers, and police personnel. When vaccination policy came, the first choice was given to the healthcare providers and the frontline workers. So this is the principle of reciprocity. So those who had a disproportionate share of risk should have get some benefit. Similarly, there is a vulnerable population. They should get the first benefit if there is a risk involved is more. The research participants should have access to the vaccine. If the vaccine participants are there, then they should have access to the, they should have first access after going through all the clearance, of course. So disproportionate share of risk gets some benefit. Principle of solidarity, because there is an intra and interdependence when you are working with the group of people in public health research. So here we need to get along people well. There should be a lot of interdependence. So community engagement strategies, sharing of information, sharing of data, the data sharing policy, updating them, what is happening with you are able to the, with respect to the research, that information, we need to involve them from beginning till the end. That is the principle of solidarity. Principle of accountability and transparency. So if you want to continue to work, there should be mutual trust. There should be transparency in what we are following, and there should be accountability, roles and responsibilities. Those who are part of the research should be well defined. Now, there are certain frameworks given by public health research. One such framework given by the Nancy ECAS. There are several frameworks for public health research ethics. This is one simple framework where there are 6 steps if you are dealing with public health programs. Now, first question we must ask is, what are the public health goals of the proposed program? If you are looking at the ethical issues in the public health program, then what are the goals? Are the goals addressing the social determinants of health? Are the goals is addressing the reducing the morbidity and mortality? So what is the for the larger good of the society? So what are the public health goals are in line with national and international health priorities? That is the first question. Then even if there are goals which are defined, like NPCDCS program, the goals are defined. There should be opportunistic screening of more than 30 years population coming to the clinics. There is a population-based screening for going house to house. Then how effective is the program in achieving its stated goals? The goals are there, but how effective is the program? Are there mechanism in place? Do we have capabilities or the financial provision for the program? Like 10 rupees, the ASHA will be given for filling the CBAC form, 70 rupees for those who are having risk score more than 4, and 70 rupees those who are diagnosed with cancer for follow-up. So whether there is any provision, we have seen in our district, out of 70 odd primary health centers, only 3 PHCs selected sub-centers, this population-based screening is happening. So how effective is the program in achieving the stated goals? What are the known or potential burdens of the program? The program, if you are looking at ethical issues, then what is the burden of the program? Known burden. So there are 3 types of risk I told you: risk for confidentiality, risk for justice, and risk for liberty. So are we going to increase the burden? Whether we are going to create more psychological harm, social harm because of that, whether there is any burden on the system. Are you going to create inequalities if you are not, if your program is not for all, if it is for only some of the people, then are you going to create more inequalities for availing the services? So what are the potential burden of the program? Can burden be minimized? If there are existing burdens, can we minimize? Can we have alternative approaches to minimize the burden? Now, if the program is implemented fairly, is it the strategy of the program is inclusive, whether vulnerable population is excluded? So that question, then how can the benefits and burden of the program are fairly balanced? Even we cannot reduce the burden, whether it is fairly distributed, the benefits and the burden. So this is a framework given by Nancy ECAS for the public health programs. Now, ethical of humanitarian emergencies like COVID-19, ICMR in 2020 has given certain guidelines with respect to public health research, where we need to fast track or expedite the process of ensuring robust ethic review, because not only the research is required to get answers for the problem because of COVID, whether it is vaccine, whether it is medicine, research is required. For that, ethical review is required, but time is less. Many people are affected, so fast track process. And the ongoing research also should go. So in view of this, the ICMR has given guidelines. Now, we have seen in case of quarantine, segregation from families, this has given a new dimension to the risk to the individual dignity, because the autonomy is relational. As there is a risk to other individuals, the individual decision-making and individual dignity and right is taken over by the societal good or societal benefit. So the dignity, psychological, emotional harm, there are a lot of social harm, informational risk of revealing the information. They may not have access to formal or informal support during these times, family counseling center, rehabilitation. And we have seen over a period of time, the changes done in the COVID care facilities and the type of services given, the restrictions are reduced, the stamping on the hand, which was more stigmatized, was removed. So all this process, it has gone to, as ethics, there were challenges. not only the individual data, we collect the location data of longitude and latitude. That is also personalized individual data that can also lead to stigma and discrimination. Now, these are again some more guidelines for the expedited review during the emergency humanitarian when there is experimental intervention is required. It is called as MERU. And through scientific review process and ethics due locally or by national level, tackle public concern, ensure oversight by the local ethics committee. Our oversight is from the consent process to the publication. Everything, is it happening as per the protocol, is ethics oversight. Use good manufacturing practices, products, make rescue medicine, supportive treatment. So these were the need during the COVID times, and the fast track research. These are the so some flexibility during the emergency humanitarian crisis, where expedited review we have discussed, case-to-case basis, depending upon the urgency it was taken. Expedited review, but as things become normal, ethics making can club the ethics if the local ethics not available, then the ethics committee member from other place can join. Common review, multi-centric research. Every center should give, the local ethics committee must give the clearance. But in case of this pandemic as a humanitarian assistance, this was said that multi-centric research is fast track by common review. Now, how to address the ethical issues? We have seen some ethical principles, ethics framework, and then how we can address the ethical issues. One such answer to this is the participate. Sometimes public health practice, which is surveillance, evaluation of program, notification, registries, demographic surveillance, and these type of research required community participation and involvement, not only participation, involvement and empowerment. And unless that is there, the ethical issues will be more. Then we'll see role of ethics committee and public health research proposal when it comes to you, what way you can review the process. Now, there are certain principles of community engagement. Because community engagement is required, but the goal and purpose of community engagement can vary depending upon the type of public health project or research you are undertaken. Depending upon the goal of the project and the research, your goal for community engagement will change. We need to understand the community culture, economic conditions, social network, political and power structure for community engagements. Establish trust and seek commitment for from community organization. So without trust, we cannot straightway start community engagement. Lot of informal discussion, meetings, building trust, and it is an ongoing process. It is not one-time process, and we must take commitment from that about the rights of the people involved, those who are part of this community engagement. There should be not passive involvement, but partnering with the community. When we can say partnering, they should be part of deciding the research agenda as well, deciding the service agenda, identifying the problems and finding, suggesting solutions. They should be as a research partner, they should be a research partner. Respect, recognize diversity of the community. This is one more principle. If you want to sustain community engagement by identifying assets, because your project will be over in 1 year or 2 years, how you can able to continue to pass on the benefit of this intervention over a period of time. So empowerment of the community is required. We need to identify the existing assets in the community resources, strengthen them and build their capacity so that there will be sustaining community engagement. If you do that, next time you want to engage with the community, then they will welcome you and you will have good participation and good outcome. Again, when you are involving the community engagement member, we must ask one question: what way the member is going to strengthen the community engagement process? What way they are going to strengthen, or what way they are the roles and responsibilities? So we need to involve those who can contribute in the community engagement process and in the research. Now, there are how we can have community engagement. We can have community engagement forum. So that forum can meet, that can have the forum members can be depending upon your type of research you are involved. If it is under 5 child, if it is a geriatric population, if it is sanitation campaign, if it is immunization campaign, depending upon the type of participants or beneficiaries or project involved, the community engagement forum members will change. But those who can be part of the decision making, like Panchayat members, Asha and Anganwadi, our healthcare providers in that area, practitioners in that area, NGOs, those who are working in that area, they can be part of the community engagement forum. Also, we can use the terminology called as local engagement forum. Nowadays, if you are writing any extramural grant which required community-based participatory research, we must explain in the research protocol, community engagement strategies and how you are going to constitute the community engagement forum. There is one more, community welfare board. So even if you want to, we must pass on or the benefits of the research should continue, the participants should continue to get even after the project. That's why there should be community welfare board. And even when you are planning your research or a part of research fund, you should consider funding the budget for community welfare board as well, or community engagement forum, their meetings, their discussions, all this you should budget for. What are the roles and responsibilities we should define? What way they are going to contribute, we should design. And when you are, what type of strategies you are going to use for community engagement? So what are the participatory approaches? Are you going to have focus group discussion? Are you going to have force field analysis? Are you going to have participatory mapping? Are you going to have problem tree? Are you going to have preference solution tree, seasonal? What are the different types of participatory approaches through which you are going to interact and have an engagement strategy? And how frequently you are going to engage? What is your data sharing policy? How much data you want to share about the project? And all this depends upon the community engagement goal. When you are dealing with community, there is a power equation in the community. There are participants, citizens, there is a research institute, and sometimes multiple research institutes are involved. There are gatekeepers, we have already discussed, one who opens the gate for the researcher and take them to the beneficiaries. And there are funders and sponsors. So always, if you see, there are power equation. As the institute, as a doctor or public health specialist, definitely our understanding and knowledge will be more. So how we should help them, community engagement strategies will help them to bring them on one page so that they should be able to understand in their own language. The community participants or stakeholders will explain the beneficiaries about the research, ethical issues, what is the risk, what are the benefits or the objectives, the technical scientific terms we may not be able to explain. Then the power equation we can reduce if you involve them from the beginning. So this is one area we need to address. Now, how the partnerships are established? Is there because of power equation, it is a partnership is because of they have to come for the center for availing services? Are you going to say no to them, or whether they are thinking that because if I say no to them, whether they will not able to get any services from the center? Anyway, as we as a standard protocol, we mentioned in our PIS that they are not going to have any hazards or harm if they don't participate, and they can leave anytime. So what is how the power is distributed, how the control is exerted? These we need to understand as a ethics review, how the protocol is written and about the community engagement and participation. Now, sometimes what happens, the community engagement, most of the time it is a participatory research, qualitative research, mixed methods approach, and to conduct the FGDs, in-depth interviews, we require people, those who understand the local language. So, and if there is a research service related, you are distributing dustbins to the participants, then there will be members from the community who are part of this process or implementation. No, it should not happen that they should not select the beneficiaries on their own. There should be some process of selecting. You should have inclusive strategy. if the problem happens if there is a less resources and there are more demand if it is a service oriented project. So these are some issues. Then we need to define the who represents community, defining the community inclusion criteria that already we have discussed. Now, who owns the data? We collect the data, we publish the data, then always we are blamed that academic exploitation of community data is done by the academician. There are economic and socio-political consequences. If the disease is associated with stigma and discrimination, there can be stigmatization of the community. Then when we are interacting with the community through community engagement forum and the stakeholders, there should be clarity who owns the data. So whether they want to be use the data, own the data, discuss, negotiate before the research start. If there are any financial rewards, if there is a total sanitation campaign and the village got some prize, so who will get the financial rewards? That also, because there are more than one multiple research institutes involved, funding agencies involved. So who will get financial reward? That should be discussed and decided with consensus well in advance. Sometimes if it gives credit and it is no stigma and discrimination, the community members may say that they wish to be named and credited, but sometimes it is a stigma and discrimination. They will say we don't want to be revealed. So community risk and benefit we need to weigh. We need to help them understand. Sometimes they cannot understand the risk and benefit of the consequences of sharing the data. But through the community engagement strategies, we should help them to make understand their unfelt needs will get converted into felt needs and they should be able to make rational decisions. So then we can ask them whether they want to reveal or not. But sometimes group data from a large site, you may not able to secure the anonymity with respect to the groups, with respect to the district, with respect to the state or the part of the region involved. Now, what are the obligations? Services even after the clinical trial. So this is services even after the clinical trial also. We need to services even after the clinical trial, we should be able to continue to give products being tested. So sometimes vaccine trials has been done. So they may say that we should be the one who should receive the vaccine. That is okay, but the all process of licensing and permission should be done. Then only we can say that yes, it is possible after that. So surveillance mechanism, what is the obligation? How we can protect the surveillance data to avoid the harm that what we have discussed. There should be community welfare center, board, name it, community engagement forum, which should continue to work even after so that we should able to transfer the skill, empower them to continue to support the community, identify the existing resources. There are cultural factors as a researcher we should identify. There is a gender inequality, the healthcare practices, childcare, rearing practices, rituals, myths, how people greet each other, how they sit, what the status of women in the society, how the decisions are made. All these are the cultural factors. And when we are dealing with community with respect to qualitative research, participatory approaches, then we must understand cultural factors so that we should be able to get the quality data. What we can do for cultural factors? We must recognize that it exists, respect the cultural factors, use simple language, symbols, your non-verbal behavior matters a lot. And sometimes the cultural factors are good and we can use it as a positive force for your research. What is the role of ethics committee if the proposal comes to you? They should ensure that the researcher has taken adequate measures for data security, confidentiality of information, whether it is public health service or research disclosure permissions. EC member need to give appropriate importance to social benefit, public good and public health impact of the study. So we have seen in the principle of social benefit. They must take decision regarding consent, whether it is a two-stage consent is required, whether it is not possible to take individual consent, whether the community consent is enough. Whether there is a consent waiver can be given, depend as it is only to improve the program outcome and not to publish the data. Even if there is a want to use the secondary data, the information has been de-identified with respect to the participants, and adequate processes has been followed with respect to disclosure, identity, and all. So in case-to-case basis, we can take a call about the consent process. Sometimes the ethics committee, which is part of the reviewing the proposals, may not have a public health expert. So they must include one expert who is from public health background, or depending upon the nature of the project, if it is on nutrition, if it is on some other interventions. So the experts from that area we should involve, because public health is little bit research which is little bit more complex, as there are governance, there are policies, there are government policies, all there is an interplay between that. So it required the subject expert in that area. What are the standard of care we are giving? If you are identifying, doing contact tracing and all, if it is a part of service also, what is the standard of care you are following? Are you only identifying, notifying and not providing them any care? Or if you are notifying, you have to link them to services. Screening and not providing services is unethical. So if you are screening them, we must have access to care. Stakeholder engagement, how it is defined, who are the stakeholders, what is the strategy? Always there should be a strategy to scale up and advocate, promote, uptake, and sustain the public health. Now, ICMR has given guidelines for research review. The first point is whether the scientifically sound objectives are there. We have seen in the public health program framework, we need to look into the program goals and whether the strategies are in place with respect to expected goals. Similarly, it is not that scientific review board only can look into the scientific objectives. As the ethics committee member, it is not only for public health ethics, but for any ethical review, scientifically sound objectives, methodologies, critical to look to understand the ethical issues. So if the scientifically sound objectives are not there, then the methodology may not be correct and the ethical issues may not have been addressed well. So it is true for both types of research. Is the individual written informed consent is required, or only community consent is adequate? If not, then gatekeeper consent permission is sufficient. So who is the gatekeeper? How this gatekeeper was decided? Who represents community? How it was decided? So is it a two-stage process or one-stage process? These are some checklists as a review you should look into. If applicable, then is respect for communities applied through community engagements. So the community rights, dignity, respect for community has been applied through community engagement process, and whether the methodology of community engagement is appropriate. Which segment of the population is likely to be beneficiaries and what are the expected benefits? Whether the benefits are inclusive, whether some segment of the population are ignored, those who required it more. So that part we need to look into. Is the individual harm is overriding the potentially larger societal benefit? Okay, so if so, in case of pandemic COVID, we have seen, so is it justified? Whether there is a strong ethical justification for do that because it is going to protect the other individuals. Now, what are the different types of potential harm? We have seen the social harm, psychological harm, physical harm. So there are potential harms. So we need to anticipate what are the potential harms and how the protocol has addressed the harms, identified and addressed the harms. Who would be harmed as a part of, who are the people are going to have more harm that we need to look into. What if any measures are taken to mitigate or minimize the harm? Harm is there, but are there any measures taken to minimize the harm? If there is an infringement, then whether there are less means to have more, less means to be more restrictions. So is the harm fairly distributed? Okay. How do societal benefits override the individual harms? Is societal justice considered while designing, implementing, assessing outcome of the study? So this is part of the principle. Now, post-research, public health intervention, access, benefit sharing, use of findings, sustainability of public health actions, how you are ensuring whether there is any mechanism for post-research benefit. It is not only post-research, we have discussed post-service or project also. If there is any service-oriented project or which is not research, but it is service-oriented project, then also how the benefits they should continue to get even after the project is over. Which section of the population are likely beneficiaries? What are the expected benefits? So these are some of the points. Now to summarize, public health ethics is applied to both practice and research. And it is difficult to differentiate between practice and research, because if it is only practice and we are not use surveillance data and we are not going to use it for research, then there may be a waiver of consent, provided we are following the precautions to avoid the harm of disclosing the data without any precautions. And there are guidelines for the surveillance data to be shared. Research, of course, community engagement process has to be there. Then there should be ethics committee approval, ethics oversight should be there. Then whether two-stage consent process is required or one step is okay. Community engagement, we have discussed role of ethics committee, what they should look, and ultimately the focus should be on common good, equity, solidarity, reciprocity, proportionality, population well-being, accountability, and transparency in public health ethics. So these are references. Postgraduate, you must go through the ICMR 2017 guidelines. They may be revised guidelines are going to come. They are in. I've been told they are in draft regulation. So we may find some more revisions. But in chapter 8, it is given about public health ethics dedicated chapter. And there are some subsequent chapters where behavioral science research, some ethical issues has been addressed. You can go through it. WHO guidelines on ethical issues in public health surveillance are available. 17 guidelines are there. And there are some ethics framework for public health given by Nancy Kass. So I would like to acknowledge the Inter-Academic Postgraduate Program, IAPSM Karnataka chapter, and our own Center for Ethics of NAPA deemed to be university for providing this Zoom platform so that we could able to accommodate a good number of participants, and there is no time restriction. So I'm done with my presentation. Then we can have the interaction now. Thank you.
Thank you, Dr. Abhay, for your wonderful presentation on basics of public health ethics. I don't see any questions in the chat box so far. If there are any, you can raise your hand, unmute yourself, and ask questions, please. Any participant, if he or she has any questions, raise your hand or unmute yourself and ask questions.
Good evening, sir. Sir, it's Arush Desai from Yenepoya Medical College, MBBS 1 from 2021 to 2022 batch. So I had a question that as a student, as an MBBS undergraduate student, if we go into the community, then how shall we identify the gatekeeper as a student? So
how we should identify?
A gatekeeper as a student.
Yeah. So if you have seen in your family adoption program, we had our team was there, which are the healthcare workers from that area. Those who have done their groundwork. Say, suppose in case of family adoption program, your gatekeepers, those who take to the family, will be who can be the people who can take you to the families, those who are going to adopt. In, for example, either there could be a panchayat member, there could be Asha or Anganwadi from that area, or healthcare workers who can take you to the beneficiary or the gatekeepers, and who represents communities. The another answer we should ask whether who are the people usually the decisions are made, the adults in that village, what is the political philosophy, how the decisions are made. So depending upon the nature of work, who are the people who can take you to the beneficiaries are the gatekeepers for it.
Okay, sir. Thank you, sir.
Anybody want to add? They are free to add.
Good evening, sir.
Good evening, madam. Yeah, good evening, madam. Yeah.
Excellent presentation, sir. It covered almost every aspect of public health ethics. So I also learned something new, that we should budget for the community, engagement. community board. So I was just thinking we can even add a budget for ethics oversight, because sometimes we don't budget for that, and then people cannot travel to do the ethics oversight. So these are some things which we really do not know, and it is very good to know about these, little hiccups that can come in a, larger framework of public health ethics. Thank you, sir. Thank you, sir. That was all I wanted to add.
Yes, madam. Yes. Thank you, madam.
Any more questions or some points to be added by anybody?
So one more question, sir. So in the case of this ethical clearance and all, sir, so what are the measures that the bioethical team, that ethical clearance team, terms the product, whether it is beneficent or maleficent for the community, or whether it is like whether it will like favor the committee or whether it will not favor the committee? What are the certain measures that on what grounds do they think that that project will aid it or not? Maybe tomorrow that thing will be taken as some other in a non-favorable manner also. So what are the various measures they take?
So see, there are set amount of guidelines. There are 4 basic principles of whether are we taking a written informed consent from the participants, whether there is any capacity to give consent, whether they are in a position to give consent, whether they have a capacity to give consent. So you are involving people, those who are 1 minute. So whether the consent is properly taken or not, and are there any risk? For one example, I will tell one. You are doing screening for, say, suppose cervical cancer. So are you going to, what is your strategy? Are you going to involve the people, those who are, you are easy to access, or are you going to take the people, those who are more vulnerable? So how the strategy is? Second, are you identifying them, and what is about the access to care? Or somebody will not participate if there is any study arm and control arm. What measures you are doing for the control arm? Is there any standard of care existing? So it is, I think it is there. It required a full session, but if you follow the principle, what we have discussed, we should be able to address the components. And
okay.
Yeah.
Okay, sir.
I appreciate, Arush. I appreciate your interest, and that we'll have more discussion. And anybody who wants to simplify, Arush, and explain? Yeah, please.
Yeah, good evening to all. Yeah, so with respect to the same question, what Arush had asked, like how does the ethics committee review or is assured of that there would be beneficence to the participant or the community and not non-maleficence? So there are certain in-check or inbuilt mechanisms that are being incorporated by the ethics committee also, where they do interim review of the data collection tools, the informed consent forms that are being maintained by the research investigators or the research team, as well as if you are as and when you would be conducting research, you would appreciate that the informed consent form has the contact details of the ethics secretary as well, or the ethics member, so that if the participants, the research participants in the community, if they have any concerns, they can reach out to these members at any given point of time, apart from the research team also. Besides this, even the ethics team, they do make interim review visits to the trial sites as well. And that is the basis of why the ethics committees, they give ethics approval to certain research projects only within a given confined geographical area, not to all over any research project that is conducted in any part of the country, so that they can make on-site visits to the community as well for the trials, for reviewing of the trials. So these are some of the inbuilt checks that the ethics committee keeps to ensure that the research projects follows all the ethical guidelines and ethics principles.
Okay, ma'am. Thank you.
Thank you, Dr. Poonam. Yeah. And see, the ethics committee will also use a checklist that what we have discussed in the public health research ethics review, 9 points we have seen. And as a researcher, we need to explain these are the potential harm, these are the potential risks and benefits, and how, what mechanism we have in our project or research to minimize the risk and maximize the benefit. So they will also see whether the anticipated risk and benefits are there, or there are anything the researcher has not anticipated, and whether there are any mechanisms in place to minimize the risk. So depending upon the topic or research or intervention, the risk and benefit will vary.
Okay, sir. Thank you.
We request the participants to kindly mute if they do not have anything.
Any more questions? Yes, Reshma, raised hand. Unmute yourself. Okay. You have to ask the presenter only. Dr. Abhay will decide. They are asking whether we can get a recording of this. Okay, that's...
the answer is yes, sir. Only thing, we'll just see the host is different. I will collect and we'll share that. No problem.
Yeah, okay, that's fine. Okay.
PPT for sure. PPT for sure, we'll share.
Yeah, okay, sure. Thank you. Yes. If there are no more questions, I would like to thank...
Sir, I just wanted to, sir, if I may be permitted,
Yeah, sure, yes.
I just want to compliment Dr. Abhay that, he's, I think within a very short span, he's touched multiple spheres in the public health ethics. And I think he's done a very good job, I think. So that's one good thing. What I was saying is, this is kind of a sensitization. Those who are interested probably can look up a little more, but I think he's done a good job. One more thing is, I think he's also mentioned, please remember that those principles are there. When it comes to public health ethics, many things like he's written, autonomy is relational. So it's not that, absolute. When it comes to public health, things like you would have seen in COVID vaccine or whatever. So many things become like, it's not absolute autonomy, which can be sometimes, even if you look at those surveillance programs or even polio eradication, that polio drops to be given to all children as far as possible within the age of 5 years. So all that we have to remember. So public health, that's where the difference comes. When it comes to public health, when you're looking at the larger good, you might have to look at sometimes, it's not that you're going to harm somebody, but trying to minimize as far as possible, but at the larger good. So I think he's given a very good overview. He's given you a lot of things, including about how the ethics committee looks at. And so I think this is a good sensitizer for many of the postgraduates. And I think this is a very important component when it comes from the point of view of exam, as well as from the point of view of their knowledge base. So I think, thank you, Dr. Abhay. And I think this is a very good starting of IAPP's revival. Thank you. Thank you, sir. Anna Rao, sir.
Thank you.
To add to that, he is not in Mangalore. He is in Mumbai, gone as examiner, and still has taken out time. And he has presented because he said, I have already committed. So even if I'm in Mumbai as examiner, I will take this session, sir. Thank you, Abhay, very much. And I cannot thank you enough. I should thank Poonam also, the Yenepoya University and Institution, because they have provided this platform, free of cost, without limit on the time and number of participants. We were just wondering what to do, how to go about this. Anyway, we had a wonderful beginning. And I just wanted to announce that next session will be on health economics. And I would be taking that session. And tentative date is on 16th of December. All details will be posted shortly in all the groups. Okay. Anybody has anything to say, or otherwise we will wind up?
Sir, just once again, I would like to thank the participants and the senior faculty members, those who joined. That is really a great boost. So thanks for the faculty members also to be part of it and the postgraduates. And thank you, sir, for this opportunity. Thank you so much.
Thank you. Thank you all. Wonderful. Okay. Hope to meet soon. Yes, Poonam, do you have to say anything?
No, sir. Thank you all. I think it was a good participation from all. So we had a good number of participants.
Yes, wonderful.
Quite encouraging.
For IAPP, yes, IAPP under IAPSM. Okay, thank you. I think we can call it a day.
Thank you, sir. Thank you all. Thank you all.
Thank you all. Thank you.
Sir, 1 minute. Dr. Reem is here.
Yes, sir.
Reem, thank you so much. I forgot to thank you for coordinating all this. So thank you, Reem, Fatima, and other postgraduates for coordinating all this background work. Thank you. Well done. Well done.
Thank you, sir.
Thank you, Reem and Fatima. Thank you.
Thank you, ma'am.
Yeah, thank you, one and all. Thank you.